maybe people don't know the connections among snoring, insomnia, and sleep apnea.
Okay.
That may be that may not be a straight line.
Mm-hmm.
It may be some other kind of shape.
Right.
But can you, for our listeners, tell us what those things are and how they differ from one another?
And the study of sleep is just so fascinating. And to get to your question, insomnia versus sleep apnea, these are two of several different sleep disturbances. Insomnia is the inability to begin, maintain, and have a high quality of sleep.
So that's insomnia.
That's insomnia, and it could be from psychogenetic origin. It could be from medications. It could be from behavioral problems.
Like leaving the TV on.
Like leaving the TV on, or
having somebody else up in the house and chatting.
I mean, ever since Thomas Edison invented the incandescent light bulb, our circadian rhythm has gone into a free fall, and I mean, we're terrible sleepers. Our children are awakened at the worst possible time we could awaken them for memory consolidation and restful sleep, etc. And we just are terrible at all of that. But as far as sleep apnea versus insomnia, sleep apnea is a different category of sleep disturbance. It's a sleep disordered breathing. It has to do with how the air goes into your body and gets to oxygenate the blood to the brain, so the oxygenated blood can go to the brain.
So it's not sensory the way insomnia is.
Not obstructed sleep apnea, central sleep apnea, which is tied more closely to the neurological disturbance, which is probably about I want to say 5 to 10% of the apneics, but the type that I'm treating, and so central sleep apnea cannot be controlled by what I do. That is controlled by other methods. But obstructed sleep apnea, which is an obstruction or a blockage of the airway, is what we treat. So back to the question, the result is the same.
The result is
the same for when you're in your waking hours, which you are, irritable, moody, tired, downright mean sometimes, because you're not properly sleeping. So the results are the same, but they are actually two completely different categories: insomnia and sleep apnea.
And your suggestion is essentially that people should ask if they're having any of these problems. They should ask the dentist.
Well, that's a bit of a loaded question. I would say it's the other way around. The dentist should be the ones that are, as any healthcare professional, should be much more aware of it. Nurses, dentists, physicians, let's face it, physicians don't have the time to spend with the patients because of the way our medical insurance and model is set, unfortunately, right now. It's more quantity than quality in a lot of times, but there's nowhere near enough emphasis placed on this. But so my answer to your question is the dentists should be the ones that are screening these out, and it's very simple. As part of a review of health history, I mean, you can see the 100-pound overweight male with a 22-inch neck come in, and that he is fits the mold. Not that that's always the case, because there are, again, we've been fooled often, but so it should be. I would suggest, that people just be more aware of it, but the dentist should be, the physician should be as well, and that's been part of this now going on 4-year focus that I've placed on this. Is part of it is educating the general population, as well as other dentists, as well as physicians, and that's why I'm so thankful to be able to have this talk, so that the word can get out. And believe me, the problem is so prevalent that not just my little office in Orleans is can handle all the apneics on Cape Cod. We have people coming from Upper Cape, Lower Cape, Mid Cape, and that's because I'm tied in with some of the physicians relative to they know that I do this, and they know which patient, that because I've educated them, they know which patients this applies to as opposed to what they're treating or how they're treating. And the goal is to have better medical outcomes.
Right. You brought a device to help explain what you do. If someone came into your office and said, I had my yearly physical, and I was told that I should consult you. So
we have certainly an educational tool again to be able to show people exactly what their particular case, again treating the individual, because every person is different, every situation is different, and there are maybe I would say 20 to 30 different appliances. And now I hate to use the word appliance because everybody thinks of their refrigerator or their stove. But when dentists use words all the time that are kind of really scary or probably ridiculous sounding words to a lay person. But the appliances are devices, if you would call them, are custom made mouth guard-like devices that a patient would put in their mouth that night to reposition their jaw slightly forward and slightly open.
Slightly forward on the lower side.
Slightly forward on the lower and slightly open to be able to open the airway to allow them to breathe properly.
Oh, well, that actually makes sense, because in meditative healing breathing, in prayer, in other situations, one is always encouraged for deep breathing, healthful breathing, to breathe in through the nose and out through the mouth. And in order to breathe fully out through the mouth, one has to.
Right.
I mean, really let the jaw drop.
And that's what we're trying to promote, exactly. Think of a lot of people know CPR.
Right.
Well, what's the first thing we do when we do CPR is A, B, C in CPR is A is open the airway by tilting the head back and pulling the chin forward. The head tilt, chin lift maneuver in
like
CPR,
this?
And yes, and that's how you open a patient's a victim's airway, if you will. Yeah. So that's what these do, and so this is a model of how one would be made of one, and it actually fits on either arch, and they both go in at the same time. Then it has an adjustment, and it actually brings the jaw forward as we adjust it, again, for each individual. So how we determine that is by means of x-rays of the patient's jaw, as well as basically me from experience knowing where their jaw has to be to open their airway, and it's they're custom made, adjustable, and there are ways to manufacture them and then test them for efficacy.
And how easy are they to get in and out? Are they a big problem?
Very simple.
Very simple.
Yeah. We find that these are much more tolerable than a lot of the current treatments are what's called a CPAP machine. Are you familiar with that?
Yes, I am, but tell our listeners
what it is. Okay, so a CPAP machine is basically a mask similar to an aviator's mask on an airplane and a jet and a fighter jet that basically shoots air into your mouth at probably 20 miles an hour.
Yeah, so it's continuous
positive
airway pressure. And that's why it's called CPAP.
CPAP, correct.
Yeah, so a person wears a thing like this with a cannula, right?
So, yeah, either or. And but basically their airway is still closed because their jaw is still dropped back, so that has to be forcefully shot through that crimped hose, if you will, of your airway. 50% of the people wearing the CPAP machine are not tolerant of it. So
yeah, right.
That's when we have a physician commonly who has a patient who refuses to wear their CPAP. Their blood pressure is not going down, their diabetes is not improving, their obesity is not improving. They need to know the importance of wearing that CPAP, but they refuse to it for a variety of reasons: claustrophobia, drying out of the tissue, the hose wrapping around, the noise. There are a lot of excuses not to wear it, but So the physicians now know that some of the physicians now know that they can refer to a well-trained dentist who knows how to manufacture these and follow the case through from start to finish.